right, welcome back for hour two. We're going to pick up with arthritides and also go through metabolic conditions. So I just wanted to introduce the kind of general categories of arthritis. There's three major divisions, one being inflammatory types of arthritis, second degenerative types of arthritis, and then metabolic types of arthritis with examples beneath. There are some general patterns of involvement that we see with these like subgroupings. So for example, inflammatory joint disease in general has a propensity to affect multiple joints on both sides of the body, inflammatory based erosions and or joint space narrowing that tends to be uniform and symmetric around the body. And often a lot of other systemic manifestations. So like in the case of rheumatoid arthritis, for example, patient may have associated lung disease or, associated vascular disease associated with the general inflammatory nature of the condition. And then we think about degenerative types of arthritis where inflammation is not the cause of the problems. And typically we see things like non-uniform joint space narrowing, kind of haphazard joint involvement, not necessarily bilateral. And so we'll go through some of those. And then the metabolic types of arthritis are all kind of deposition-based conditions like gout, CPPD, and hydroxyapatite. So jumping right into rheumatoid arthritis in that inflammatory category, I really just want to take a moment to digress to kind of an additional division that we make within inflammatory arthritis. And so if you think about inflammatory arthritis as like this umbrella term, right? Inflammatory arthritis, there's things that test positive for rheumatoid factor and things that test negative for rheumatoid factor. And rheumatoid factor is something they look for in the blood as like a marker typically seen with certain types of arthritis if present. And then other types have a tendency to be seronegative. So if we think about conditions that test positive for rheumatoid factor, just to back up for a moment, rheumatoid arthritis is the most common inflammatory condition in general, but also lives in that, rheumatoid factor positive nature. Same thing with lupus, same thing with scleroderma, also things with like Sjogren's syndrome and other kind of autoimmune based, often connective tissue or even just inflammatory joint disease type of diagnoses. And things that classically test negative for rheumatoid factor are the seronegative spondyloarthropathies, to include ankylosing spondylitis, its radiographic twin, enteropathic arthritis, and then psoriatic and reactive arthritis. Excuse me. These generally test negative for rheumatoid factor and very often may have another marker in the blood that's most often present with ankylosing spondylitis, and that's HLA B27. Sorry, I'm trying to draw this with a mouse. But HLA-B27 positive is something we typically see with AS, but can be seen in some of the other seronegatives as well. So keep that in mind in terms of lab findings associated with inflammatory joint diseases, as you do expect, for example, erythrocyte sedimentation rate to be elevated, but you don't expect all of them to test positive for rheumatoid factor. All right, so picking it back up with the discussions about rheumatoid, let's remember the real basis of rheumatoid arthritis, which is synovial inflammation. Synovitis is really at the basis of rheumatoid arthritis, which means that synovial-based articulations are really prone to involvement. Now, when we think about classic locations of rheumatoid involvement, it's really the small articulations of the wrists and hands that are most commonly affected. And of course, synonymous joints in the feet can be involved as well. The earliest findings we see in rheumatoid arthritis are based in the pannus formation that the synovitis produces. And the first place that pannus really starts to destroy bone is in the bare area of a joint. And I'll just remind you that the bare area is a region within the joint where the bone is not covered by cartilage and the synovium lives directly on the surface of the bone. This is the location in which early erosions are most likely to be seen. And when we think about early radiographic findings, soft tissue swelling is naturally something that we can pick up on radiographically, but it's not a very specific finding, right? There's a lot of clinical manifestations of rheumatoid to include joint pain, reduced range of motion, like joint stiffness, right? And actually, rheumatoid is very often diagnosed as a diagnosis of criteria, where a certain number of criteria need to be reached to establish a likely rheumatoid diagnosis. And then, of course, the lab tests will support it. Radiographically, we expect to see early involvement at locations like the metacarpal heads, and you can see in the image off to the far left that the metacarpal heads have extensive erosions bilaterally present in not only the bare area or the margins of the joint, and sometimes you'll see it described as that marginal erosions within the joint, or what do they call these? Rat bite erosions associated with the periphery of the articulation in that bare area, and then it becomes progressive, right? So the articular surface becomes more extensively involved. Other locations in the wrist and hand that RA really likes is the intercarpal articulations, and you can see particularly in the patient's right hand, let me just get my annotation tool, here's the right hand of the patient, that there's really extensive intercarpal involvement. Radiocarpal involvement is always common. We mentioned the ulnar styloid, which is a little bit out of view here. The MCP articulations, all of which are affected on both hands for the most part. And then the proximal interphalangeal joints as well. Something that's very interesting about rheumatoid is it almost never affects the dips. You'll notice the distal interphalangeal articulations in these hands are unaffected. And that's very common to see. We'll also note the deformity present here of the fingers, where there's kind of this ulnar drift of the fingers or ulnar deviation. They call this a Lanois deformity, and this is associated with, our structural loss basically from all the erosions and the subsequent malposition of the fingers. Patients with rheumatoid can have a bunch of different deformities. Maybe you'll recall the swan neck deformity and the boutonniere deformity. These are all deformities described in rheumatoid arthritis based on deformed fingers from the structural changes. In terms of other articulations that are very commonly affected, the large joints of the proximal appendicular skeleton, so shoulders and hips, very commonly affected with rheumatoid arthritis. And in terms of spinal involvement, the cervical spine is really most often involved. When we talk about this A to P, or this is probably a P to A chest radiograph, what we're noticing on the margin of the film, and really poor choice for marker placement, is the fact that this acromioclavicular joint is demonstrating pretty massive erosions with the distal end of the clavicle kind of missing. You can see the distal end of the clavicle seems to terminate about here, and they've conveniently placed the marker right within that space. And this is why we're always such sticklers with radiographic positioning, because you can easily cut off anatomy or put a marker in the wrong spot and obscure findings. At any rate, AC joint is another location that osseous erosions can occur. And remember, it's a synovial-based articulation. Now, in the spine, in chronic rheumatoid arthritis, about 80% of patients get spinal involvement, and it's really exclusive to the cervical spine in most patients. We're most worried about the atlantodental interval, of course, because there's a synovial articulation that lives in front of and behind the dens. So let's imagine a sagittal illustration of the odontoid process, the anterior tubercle that it articulates with, and the transverse ligament, right, that wraps around it. Okay. Now, there is a synovial pocket that lives right in the atlantodental interspace, and there's a synovial pocket that lives just behind the dens in front of the transverse ligament. So often what happens in rheumatoid is the synovitis leading to pannus formation, which is a destructive granulation tissue, will erode away the odontoid. So the odontoid becomes eroded and withered away, and before you know it, there's odontoid destruction, and possible loss of integrity of the transverse ligament and subsequently stability to the upper cervical spine. In the image off to the right, this is a T1 weighted MRI sequence image, sagittal plane of the cervical spine. And let's just point out some anatomy. So here's the inferior margin of C2. This is the inferior end plate of C2, dorsal margin of C2, and what's left of the dens. Okay. Now here's the anterior tubercle of atlas. Here's the posterior tubercle of atlas. What we're noting here is some really high signal and inhomogeneous signal intensity to the space between the basion. Remember, the basion is the very front of the foramen magnum. Here's the opistheon, the very back of the foramen magnum. And in the front, the dens basion interval is a bit increased here because of the destruction of the dens, and there's a large collection of soft tissue here that is pannus formation. When the dens becomes eroded, there's a name sign called the whittled odontoid, and this describes a dens that's been destroyed by pannus formation in rheumatoid arthritis. In terms of chiropractic, this is something we're worried about. So patients who have rheumatoid arthritis, you do want to be mindful about whether or not they have cervical spine involvement, and if so, if it's stable. So radiography naturally, and then flexion extension images with special attention to the atlantodental interval is definitely recommended in patients who have chronic rheumatoid arthritis. All right, now of the other kind of seropositive based conditions, we'll talk in just a few minutes about scleroderma and lupus and how they may show up radiographically. Lupus really lacks radiographic findings, but scleroderma has some soft tissue calcifications. But let's talk for a moment about ankylosing spondylitis. Remember, ankylosing spondylitis is also known as Bacteroux disease and Mary-Strumpel's disease. This is a condition of inflammation as well, usually seronegative relative to rheumatoid factor, and often test positive for HLA-B27. AS likes to start in the sacroiliac joints, and it really starts as sacroiliitis. So inflammation of the sacroiliac joints, and that inflammation is bilateral and symmetric. Okay. That inflammation leads to fusion of the SI joints. And if we bring our attention to the AP pelvic views here in both cases, you'll notice the absence of sacroiliac joints. The fusion is more prominent in the image to the right, and this is what we end up seeing with AS is fused sacroiliac joints. We refer to these as ghost joints, and patients may also have a really dense area of the ligamentous ossification that occurs ventral to the SI joint. And they call this star sign. That's what these black arrows are pointing to, little asterisk-like density occurring at the top of the SI joint. So those are the common pelvic findings: bilateral sacroiliitis, progressing to fusion, and star sign may or may not appear. And then it starts to progress up the spine. Now remember, AS really has 2 points of involvement in the spine. One is ossification of the anterior longitudinal ligament, and the other is ossification of the facet joint capsular ligaments, effectively fusing the spine. So the ligamentous ossification occurring at the ALL, anterior longitudinal ligament, we describe this as syndesmophytes, right? And in the case of AS, they get really thin syndesmophytes. But the ossification doesn't start right away. First, they end up with enthesitis, inflammation at the enthesis of the ALL to the vertebrae. And if we draw our attention to this lateral thoracolumbar based projection, you'll note that the corner of the vertebrae looks very dense. And this is actually a little bit of a healing response. So first what happens is there's inflammation at the enthesis, which causes an erosion. And the patient will effectively be missing like the corner of their vertebral body. They call that a romanus lesion. A romanus lesion is a vertebral body corner erosion caused by inflammation of the ligamentous attachment to the bone. Excuse me. That erosion will heal, and the healing demonstrates a sclerotic appearance. And so what we're noting at the segment above here is the shiny corner sign, or the increase in density to the corner of the vertebrae, which represents a healed romanus lesion. Now, both of these precede ossification of the anterior longitudinal ligament. So ALL ossification will come after this. And if you're looking for early signs of ankylosing spondylitis, sacroiliitis, romanus lesions, shiny corner signs are really early manifestations of ankylosing spondylitis, along with the clinical manifestation of low back pain, reduced range of motion, feelings of stiffness, generally in a fairly young patient, right? So AS is kind of a progressive phenomenon, and it really likes to start in the lower lumbar spine and then progress up to, some variable level in the spine. Enteropathic looks the exact same way, but we wouldn't use the name signs ghost joints or star sign or, romanus lesion or shiny corner. And there's a few other name signs you'll want to familiarize yourself with, like the trolley track sign, the dagger sign, and the Anderson lesion. These are all lesions associated with ankylosing spondylitis. Patients with enteropathic will generally have concurrent ulcerative colitis or Crohn's disease, some inflammatory bowel disease triggering a spondyloarthropathy. So here's an example of some of those marginal syndesmophytes that form, really well illustrated on the image to the far right. You'll notice the ALL ossification along with the outer discal fibers produces this what we call bamboo spine or poker chip spine, seen very well in the image off to the right. The image to the far left, you'll notice this very dense linear structure. This is ossification of the supra and or interspinous ligaments, producing this very linear density mimicking a dagger. And then in the image centrally, you'll notice that there are paralleling densities that we call trolley track. And some books will include the dagger sign as part of the trolley tracks. Trolleys used to have 3 tracks back in the day. And so now, there's only 2. But basically the paralleling densities of the facet joint capsular ossification along with that central linear calcification is something we see so classically in AS. So dagger sign, trolley track sign, and bamboo spine. All right, the next condition falls into the seronegative. And remember, the seronegative spondyloarthropathies we generally remember as the pair group. P for psoriatic arthritis, E for enteropathic arthritis, A for ankylosing spondylitis, and R for Reiter's. But with this pair discussion, we really can divide these 4 into 2 separate categories. One is the AS enteropathic kind of mimicked appearance of each other. And then reactive and psoriatic have a tendency to behave in a similar way. And that similar way is with asymmetric sacroiliitis for psoriatic. We talked about those bulky, non-marginal syndesmophytes that come with reactive and Reiter's in the spine. And in the small joints of the hands and feet, psoriatic really likes to involve the pip and dip joints. So it's really the pips and dips that are most commonly affected in the hands, and then the equivalent joints in the feet. And so you'll notice here involvement of the dip joint, second ray, pip joint of the fourth ray. And actually there's a name sign in psoriatic called ray sign or ray pattern, because in some instances all 3 joints of a digit are involved. And this is really characteristic pattern for psoriatic if seen, wherein rheumatoid only likes to affect the MCPs and the PIPs, and it really spares the dip joints. So that's something we kind of think about in terms of how these patterns help us make a diagnosis. But in psoriatic arthritis, they get mouse ear erosions, and they're little erosions right at the periphery of the joint. And they get a little fluffy periostitis that can kind of make it look like, a little mouse. I don't know. We're making stuff up, right? Whoever made the name sign is making stuff up. But mouse ear erosions in psoriatic versus the rat bite erosions in rheumatoid. You notice here the patient has some pretty prominent deformity of that fourth digit, proximal interphalangeal joint, and they've taken a fan lateral view here to see that proximal interphalangeal joint from a lateral perspective. You could already see from the P to A view of the hand that there's a little cupping of the distal end with some tapering of the proximal end, and they're leading into this kind of pencil and cup deformity, right? Also known as mortar and pestle. Massive soft tissue swelling is generally seen. They call this sausage digit. Patients with with psoriatic arthritis can have really prominent soft tissue swelling, and we can note that on the P to A view as well, digits involved. A small percentage of patients with psoriasis have psoriatic arthritis. Something like 5 to 12% of patients with psoriasis end up with psoriatic arthritis. And remember, they get the silver scales and pitted nails, right? And they get this pinpoint hemorrhage to those plaques on the skin when they peel off the scales. And so those are some characteristic findings for psoriatic. All right, now here's a patient with reactive arthritis, and they're really starting to develop some of those spinal findings that can be seen in both psoriatic and reactive, which is the non-marginal syndesmophyte. First, they start with asymmetric sacroiliitis, and they may progress to have these kind of bulky, appearing to float kind of syndesmophytes that are really parasagittal or paraspinal. So you see these better on AP images of the spine, and you can see these non-marginal syndesmophytes, and they're named non-marginal because they attach beyond the margin of the vertebrae. In ankylosing spondylitis and enteropathic, their marginal syndesmophytes attach exactly at the corner of the vertebrae, and they're also very thin, eggshell thin. The non-marginal syndesmophytes of reactive and psoriatic arthritis are much bulkier, they appear to float, and they attach beyond the vertebrae margin. Something that's really classic to reactive arthritis is erosions at the insertion of the Achilles tendon. This enthesitis is very common in patients with reactive arthritis. They may have pain at the plantar aspect of the calcaneus as well. If you're wondering what the opacity is on the A to P view of the lumbar spine, this is actually a KUB, or a kidney, ureter, bladder exam. They inject the patient with a radio-opaque material, and they look at the kidneys and how they filter that contrast and then excrete them through the ureters and into the bladder, commonly done to assess for obstruction, traumatic, injury to these structures and so forth. And so you can see that those opacities. All right, now here's a patient who is demonstrating some really classic findings of lupus. And lupus falls into the seropositive for rheumatoid factor category. Lupus is a connective tissue disorder that primarily, affects other systems of the body, but musculoskeletal manifestations are quite common. And the presentation is generally with deformities of joints without real kind of joint destruction or joint involvement. So you'll note in this case that the joints look normally spaced, but there is a lot of deformity of the articulations. You'll notice this patient has a quite prominent ulnar deviation of the fingers. On a lateral view, this kind of flexion deformity at the MCPs, extension deformities at the proximal interphalangeal joints, and flexion deformities here. And these are reversible. So if the patient picks their hand up and we kind of reposition their fingers and, it's a very flexible and reversible deformity. And that's classic for lupus. Patients also have a tendency to get avascular necrosis, is another kind of complication of the manifestation of lupus in the skeleton. And scleroderma also falls in that seropositive for rheumatoid factor category. And scleroderma is a condition that can affect multiple systems as well. I'll remind you about the crest phenomenon that can happen with scleroderma. Get calcinosis, and that's what we see here radiographically is some of the soft tissue calcification that comes with this. Sorry, I'm getting all mixed up here. Okay, crest. Let's just spell this out. This is a little rudimentary, I apologize, but calcinosis, and this is typically seen in the hands. You can see in both of these cases there's some calcification happening kind of in a periarticular location, but subcutaneous in nature. Sometimes you can even see it along the forearms or at other locations. Raynaud's phenomenon, that's a vascular kind of event with vascular blushing followed by constriction. It can be very painful. There's a lot of causes to Raynaud's, but it is associated with scleroderma as well. Esophageal dysmotility. Usually they have smooth muscle affected. The GI tract has some really prominent manifestations of scleroderma. Sclerodactyly, so tightening of the skin around the fingers. And very often this causes distal tuft erosions. Well, really resorption of the distal tufts. And you can see in a number of these digits what we call acro-osteolysis, acro being the distal aspect of the extremities, osteobone, lysis to break down. Acro-osteolysis, is equivalent to resorption of the distal tufts, and there's a number of differentials associated with that, to include HPT. For example, psoriatic arthritis can also resorb distal tufts, and of course, scleroderma. And then telangiectasia, which is spider veins. So scleroderma has a number of manifestations. Also, the cardiopulmonary system's heavily affected in scleroderma as well. But radiographically, you can expect to see soft tissue calcification and resorption of the distal tufts. Rheumatoid factor positive in the blood. Now here's a patient who has a very common condition that's seen in postpartum women. This is a condition that is clinically manifesting as low back pain and has some pretty prominent radiographic findings. The biggest thing with this is not to confuse it with a true sacroiliitis. Patients with osteitis condensans ilii do not have inflammation of their sacroiliac articulation. They have sclerosis of the subchondral bone below the articular surface. And this shows up as like this triangular radio opacity in the region of the SI joints. Patients, again, present with low back pain, but this is self-resolving. So really it's just, you can kind of like wait it out. But radiographically it can show up as really dense around the sacroiliac joints, but notice how smooth, and let me just take the annotation away. Notice how smooth and regular these articular surfaces are. And you'll notice on both sides. In cases of sacroiliitis, we see a serrated appearance to the articular surface. And it's a really kind of irregular appearance, roughened and hazy, to suggest a patient has sacroiliitis. So osteitis condensans ilii, non-true sacroiliitis, subchondral increase in density in a triangular pattern is what we see radiographically. Oh, look at that, pretty prominent facet joint arthrosis here between S1 and L5. Look at that, really prominent facet joint here. Degeneration. Unrelated, of course. Okay. All right. So here's a number of examples of what we see more often, which is the non-inflammatory joint disease. And these are all examples of osteoarthritis. Now, osteoarthritis is really kind of the wear and tear joint disease. And so we really expect osteoarthritis to occur in joints that are really weight bearing, or that we use quite a bit, right? Some of the smaller joints in the hands, for example, can demonstrate osteoarthritis. We expect non-uniform joint space narrowing. And what that means is that the joint is not narrowed equally throughout. The best example of this we can see is really in the pelvis here. Note in the AP pelvis, the patient's right, this is the right side, patient's right hip demonstrates really prominent superior joint space loss as compared to the other side. But you'll note that the medial joint space in both hips is equidistant. This suggests that the right hip is demonstrating joint space narrowing that's really confined to the superior aspect, which is the weight-bearing aspect of the joint. And this is an osteoarthritic pattern classically. In inflammatory joint disease, let's say like rheumatoid arthritis, there would be no selectively narrowing of an aspect of a joint. The whole thing would be narrowed to an equal extent, superior, axial, and medial, and the other hip would likely look the same, right? Symmetrical distribution. So osteoarthritis is classically asymmetric from side to side of the body and also non-uniform in how it narrows joints. We can also see things like subchondral sclerosis, really prominent in this case, and a number of subchondral cysts, also known as geodes, which can occur in osteoarthritis as well. Osteophytes, we all know, is a common feature. Now, as we come to the AP view of the knees, really classic non-uniform joint space narrowing, right? The joint space narrowing on the medial aspect of either of these knees is really prominent, but the lateral joint space is fairly well maintained. Patients can also get subchondral sclerosis, osteophyte formation, and subchondral cysts as well. Not really seen in this case. A little bit of subchondral sclerosis on either side, maybe a little osteophyte growing. In the lumbar spine lateral view, we can see this patient has a number of intervertebral disc levels that demonstrate narrowing, osteophyte formation, and in this case, degenerative slippages, degenerative spondylolistheses. There's an anterolisthesis of L4 on L5. Notice the posterior vertebral alignment is not lined up. And there's also an anterolisthesis of L5 on S1. This is mostly caused by the massive facet joint hypertrophy and sclerosis we see between L4, L5, and L5S1. Sorry, these annotations are getting a little messy. And then in the hands, you'll notice the small joints. Typically, the dips are heavily involved in osteoarthritis. The base of the thumb is another common location for osteoarthritic change. And so, areas around the body can have characteristic locations. Now, I just wanted to quickly touch on modic changes because these are osteoarthritic changes that occur at discovertebral articulations, some of which we can only see on MRI. Now, what you're most familiar with is the type 3 modic change, which is subchondral sclerosis. You'll notice on this sagittal illustration, really nicely depicted by Dr. Matt Skowski, who I'm so proud to say is a DAC and has these really great illustrations we can use for educational purposes. But subchondral sclerosis is something we can see in the subchondral bone of degenerated joints around the body. What we can't see radiographically are the two steps that precede subchondral sclerosis. So type 1 occurs when edema is present in the subchondral bone secondary to an osteoarthritic joint, right? Joint space narrowing, kind of altered dynamics in the joint, altered weight bearing through that joint can cause edema in the marrow below the articular surface. And this is really painful. When we talk about painful joints, edematous joints in the marrow adjacent to the articulation is definitely a cause of joint pain. Anyway, type 1 modic change is a edematous change, and we can appreciate this on MRI with low signal intensity on T1 and high signal intensity on T2, which is a typical combination of signal for edema. And then type 2 modic change is associated with fatty deposition in the subchondral space. So in that subchondral bone, fat is laid down. And on MRI, this shows up as high signal on T1 weighted images and kind of ISO to high signal on T2. Remember, fat can be fairly high on T2 weighted images. And so modic changes are things we can see on MRI examinations, at least type 1 and type 2, that precede the subchondral sclerosis we can appreciate radiographically and on MRI. Named by Michael Modic, a neuroradiologist who wrote a lot of papers and developed these modic changes in the interpretation of MRI. All right, now another non-inflammatory joint disease is DISH. Remember, DISH is also known as Forestier's disease, and this is diffuse idiopathic skeletal hyperostosis. And the primary mode of involvement in DISH in the spine is, ossification and hypertrophy of the anterior longitudinal ligament. Usually starting in the thoracolumbar spine, patients typically complain of stiffness but not really pain. These are middle-aged patients, and they ossify and hypertrophy the ALL. So you'll notice in this lateral cervical view, this really mature kind of bony bar living ventral to the cervical spine and appearing to be attached to it. Remember, the ALL does attach to the vertebral bodies, hence why it provides so much stability to the spine. Sometimes these little horizontal clefts are seen through the ossification, and this is normal. You can see this in cross-section on a separate patient. But anterior hyperostosis is a DISH finding, and the real clue to ensure that it's DISH is that there's no involvement of the facet joints. Remember, DISH does not fuse joints. It simply ossifies ligaments. Unlike ankylosing spondylitis, for example, it causes fusion of sacroiliac joints, fusion of facet joints, along with ossification of the ALL and some of the annular fibers. And so a lot of people get DISH and ankylosing spondylitis mixed up, but there's really nothing to mix up about them other than they both involve ALL ossification. Now, DISH causes hypertrophy, really thick anterior flowing ossification that looks like dripping candle wax. That's how they describe it. These patients can have dysphagia if this gets really prominent in the cervical spine. You can imagine the esophagus runs just ahead of this region. And so dysphagia is a complaint that patients may, kind of appear with. But one of the complications of DISH to be aware of is that patients can also ossify the posterior longitudinal ligament, which lives inside the spinal canal, and ossification of that ligament is very problematic for that reason. Remember, it ossifies and hypertrophies. Normally, the ALL and PLL are very flat ligaments. They live up against the vertebrae and are kind of flush with the surface of the vertebrae. And you'll notice in the ALL ossification, this is really hypertrophic. And the same for the PLL ossification we can see in this sagittal perspective or sagittal plane of this cervical spine in a patient who has the classic anterior flowing hyperostosis along with PLL ossification. Look at how narrow the canal is now. Now we're right at the spinolaminar junction, so this is the back of the canal. We can see we're in the midline because of the spinous processes. And I mean, really narrow spinal canal here. So we'd be worried about the cord. Patients with OPLL need an MRI examination to assess the integrity of the cord. Is there a syringomyelia? Is there cord softening? We call myelomalacia. And these are definitely contraindications to adjusting the cervical spine if OPLL is present. And so this is something to look for. DISH patients generally should not have neurologic deficits, but if they do, consider OPLL may be present. Now, another non-inflammatory joint disease is Charcot's joint, also known as neuropathic or neurogenic arthropathy. And this is really caused by loss of sensation in the part. There's many causes to neuropathic arthritis, but most commonly today is diabetes mellitus. Other causes include tertiary syphilis. Patients can have spinal cord injuries, peripheral nerve damage, and a number of neural insults, basically. And so the patients end up kind of grinding down their joints to a point that would have been excessively painful if they could feel it. And the joint kind of breaks down. There's two basic types of neuropathic arthropathy, the hypertrophic type, as seen here, and the atrophic type that can be seen in the lower extremity, but more often seen in non-weight bearing joints like the shoulder or the elbow. The hypertrophic type is characterized by 6Ds: debris, density, disorganization, dislocation, and did I say density already? There's 3 DEs and 3 DIs. Oh, destruction. And these 6Ds really kind of culminate the findings associated with neuropathic arthropathy, the hypertrophic type. You'll notice the extreme flattening of the longitudinal arch on the lateral view. You'll note the kind of mid-foot articulations are primarily involved here. Just to kind of point out, we can see the calcaneus, the talus, and the navicular. And then it's really, part of the cuboid we can still see, but the cuneiforms are really heavily affected here. The metatarsal bases are really involved. Remember, these directly articulate with those cuneiforms, and this is present on both sides. This is present and viewable from the dorsal plantar, the medial oblique, and this kind of everted view. There's a bag of bones appearance associated with this type of neuropathic. You can see there's a lot of soft tissue swelling here. This foot would appear quite deformed, really unstable articulations. And you can see from the dorsoplantar view just how the talus is articulating with the navicular, really misaligned here. These patients need orthopedic consultation, and they also need to be managed. Their diabetes, if it's caused by diabetes, needs to be managed by an endocrinologist. The fix to this is very often amputation. So patients need to be careful about developing like ulcers and stuff on their feet. They can end up with infections that can just complicate the matter. But here's just a good example of hypertrophic neuropathic arthritis. Another type of arthritis that's non-inflammatory is what we know as synovial chondrometaplasia. And this is a long name, but synovio, it's synovial based. Synovial hypertrophy leads to little chondral bodies that are produced, metaplasia, right? So the synovium is producing chondral bodies that end up breaking off and sometimes ossifying. That really describes primary synovial chondrometaplasia. And primary is really more represented here in this kind of coronal perspective of the glenohumeral articulation and a patient who has just innumerable small loose bodies floating in this articulation. Secondary synovial chondrometaplasia is typically seen in osteoarthritis, where a patient has loss of joint space, kind of chondral fissuring, little pieces of cartilage kind of break off the articular surface. The synovium may produce some as well, and they end up with a bunch of different sized loose bodies along with findings of osteoarthritis. So you'll notice this patient has some pretty large, pretty small, pretty kind of medium-sized loose bodies with a really degenerated, at least patellofemoral joint we can see is osteoarthritic, but frontal projections would likely show us tibiofemoral degeneration as well. So primary SCM is typically seen in young patients with a healthy articulation, many loose bodies, some of which are only chondral. So this is actually a good example. These loose bodies are not calcified. We can tell they're not because cortical bone is typically low signal. These bodies are iso-intense or gray, and this is similar to the appearance of articular cartilage, which means this is hyaline cartilage bodies. Radiographically, we would not appreciate hyaline bodies, loose bodies. It just brings up the point that if you suspect a patient has synovial chondrometaplasia, to order an MRI examination. Now that I'm looking at this a little more, we can see the patient who has secondary SCM probably has a Baker cyst. We can see some kind of calcified bodies, very dorsal to the joint capsule. And these occur, Baker cysts are an extension of the joint, kind of a decompressive phenomenon, and end up having a saccular protrusion of the articulation. All right, now gout is we're kind of switching modes here away from non-inflammatory joint disease into metabolic forms of arthritis. And gout is a really common form of arthritis. This is a deposition disorder. Patients basically have a defective xanthine oxidase enzyme to help break down purines. So basically, the purine metabolism is defective in patients with gout, and they end up in a hyperuricemic state. They end up with hyperuricemia, hyperemia. Hyperemia. All these terms, right? I'm just lecturing away here. But hyperuricemia and excessive uric acid. This is these films demonstrate the most common manifestation of gout, which is involvement of the hallux. Here's a dorsoplantar and medial oblique view of the foot in a patient who has a really classic pattern of soft tissue swelling, which we call this kind of lumpy, bumpy appearance. And they have these really well corticated erosions. Notice this erosion here on the medial aspect of the distal phalanx, how well marginated this erosion is. This is unique to gout. Erosions in inflammatory joint diseases are non-corticated. This just exposes the trabecular pattern, really highly inflammatory. Cases of gout, patients have these tophi that form in the soft tissue, which is a collection of these, uric acid crystals, and these tophi erode away the bone slowly. And they end up with these really well corticated erosions along with the overhanging margin sign. You can see these erosions have almost like a little awning. You imagine the tophus lives in here and the bone is almost enveloping that tophi. Gout. The lab tests for gout are really characteristic. Patients hyperuricemic, and these do really well with some intervention. Patients often need to have nutritional awareness around foods that exacerbate their conditions. Usually meats and cheeses. A lot of alcohols fall into that category of purine-rich foods. And so it's important for patients to understand how they can manage this before they get to this state, which is typically a chronic tophaceous gout stage. First, metatarsophalangeal joints most common. They call it podagra, the foot pain associated with gout. Really, really painful. Other depositional disorders in the metabolic category of arthritis include calcium pyrophosphate deposition disease, and this, radiographically causes what we call chondrocalcinosis. So chondrocartilage calcinosis, calcification. Chondrocalcinosis is most often caused by calcium pyrophosphate deposition. This is a type of crystal deposition disorder where patients end up having these crystals in their cartilage. The joint is predisposed to osteoarthritis in the presence of these crystals, so there's something called CPPD arthropathy. That's why they often call this pseudo-gout, because patients can have symptoms that mimic gout, pain, tenderness, swelling, and joints affected. Very common at the fibrocartilage of the knee, also common in the fibrocartilage of the wrist. These locations are often involved. And then there's hydroxyapatite disease, which is more of a periarticular type of involvement, usually periarticular soft tissues like bursa and tendons. And this is called hydroxyapatite deposition, also known as calcific tendinitis, a little bit of a misnomer. Can cause calcific bursitis as well, which is what we're seeing here, this really kind of cloudy, fluffy calcification occurring in that acromiohumeral interval in the region of the subacromial bursa. These can also happen at the rotator cuff tendons more often. This joint is really subluxated, unrelated, but you'll notice the humeral head's quite low. There's kind of an equivalent Shenton's line here that we can do like in the hip. This is a really inferiorly subluxated humerus. They call this luxatio erecta, interestingly, unrelated to the hydroxyapatite, but I don't know, maybe. This is maybe a little space occupying. Anyway, when you look at radiographs relative to arthritis, it's really important to just kind of look to see what's going on, and that's in any case of radiographic interpretation. But you want to consider the history along with the radiographic presentation, along with what they're asking you to answer the question most appropriately. Now, there's a few metabolic conditions to go through, and then we'll wrap up this lecture. We'll go through osteoporosis, hyperparathyroidism. I will also go through osteopetrosis, and then rickets and scurvy. All right, so starting with osteoporosis. Remember, this is best diagnosed with DEXA. There's a number of complications that can happen with osteoporosis, and we really think about fracture and risk of fracture. So let's talk about the fracture patterns we can see in osteoporosis, the most benign of which is kind of the biconcave vertebra we see in the spine, where the end plates get really concave relative to the vertebral body. And this is, really classic appearance in osteopenia and osteoporosis. If we come to the image off to the far right, this patient also has these biconcave compression deformities leading to what we call fish vertebra or codfish vertebra. But another fracture pattern that we often see in osteoporosis is the compression fracture, and we can see kind of this prominent compression in the mid-thoracic region. Compression fractures can happen in anyone, but patients with osteoporosis are just more prone to fracture their vertebrae. And then the more worrisome vertebra plana, right? Like here's an example of a really flattened vertebrae. Remember, vertebra plana has some really worrisome differentials to include multiple myeloma and metastasis. And the most benign differential for a vertebra plana is osteoporosis, right? And so this is another fracture pattern we can see in loss in bone density. And then, of course, the hip fracture, right? Generally intracapsular, subcapital location, as seen here, just below the femoral head, fractures very often in patients with reduced bone density. And so these are some of the concerns in terms of osteoporosis, adjustments and so forth. So there's a number of conditions that can lead to loss of bone density, but remember, osteoporosis can exist on its own. DEXA scores of negative 2.5 or lower are considered osteoporosis. Now here's an example of the most common manifestations of hyperparathyroidism. Now remember, hyperparathyroidism stimulates the release of calcium into the blood. And the best reservoir we have for calcium is the skeleton. So we end up leaching calcium out of the skeleton and putting it into the blood. As a result, a lot of soft tissue calcification occurs. Bony resorption is how we liberate calcium from the skeleton. And so this really characterizes the radiographic findings we can expect to see with HPT. Okay, resorption of bone and soft tissue calcification. You'll notice in this A to P view of the chest, usually chest is taken P to A, but you can see this is mobile and erect. That means that the patient was on a gurney and they were just imaged in kind of a seated position. But you'll note here the resorption of both the clavicle and the acromion, grossly widening the acromioclavicular joint. And this is happening on both sides. You'll also notice the patient has really massive soft tissue calcification in and around the hand. They have resorption of the distal tufts, which is something that acro-osteolysis we mentioned before, which can be seen in other conditions. And then resorption of cortical bone. They call this subperiosteal resorption. This is usually seen in the hands and often quite worse on the radial side, not so prominent here. But resorption at the sacroiliac joints is really common as well, making them wider than usual. And particularly in secondary HPT, which we know as renal osteodystrophy, patients end up with rugger jersey spine. And that's, characterized by this kind of dense band along the top of the vertebrae, this radiolucent intermittent region, and then another density at the bottom, rugger jersey. Now, osteopetrosis, also known as marble bone disease, is a condition where patients fail to maintain a trabecular space. They end up with cortical bone throughout, effectively. Now, this more so falls into the dysplasias category, but it is a metabolic phenomenon. So basically, patients don't maintain that trabecular space in the remodeling that's ongoing with bone. As a result, they get really dense bones, hence the name marble bone disease, or petros, which is to harden. Marble bone disease or osteopetrosis is problematic for a number of reasons, one of which is that the bone is more brittle because of the cortical bone throughout. Bone is strongest with a trabecular space and a cortical shell. Too much trabecular bone, too much cortical bone throws off the strength of bone. And so pathologic fracture is something that happens quite often. And if we look at this A to P view of the pelvis and kind of upper portion of the thighs, this patient has a really prominent fracture deformity at the proximal end of the femur. This is true for a number of ribs as well. On top of the fact that patients can't do much hematopoiesis. Remember, the trabecular space, particularly in the axial skeleton, is the major site for hematopoiesis. So patients end up with anemia, they're prone to infection, they can't produce enough red and white blood cells, so they can have a number of problems associated with that. Radiographically, there's a couple of findings to be aware of. Obviously, the very dense appearance to the articulations, but often we see what's called this kind of bone within a bone appearance, or an endobone. So it's almost like a bone mirrored inside of the bone. You can kind of see this at the proximal tibia as well. Distal femur, we can see this from a lateral view. And sometimes you see really prominent, almost like these radiating densities in the pelvis, as if they have multiple pelvises within a pelvis. On lateral views, vertebrae will have a finding called sandwich vertebrae, and they end up with really dense end plates. I don't know if Dr. Wong put an example in here, so I'm just going to kind of draw it for you, but really well delineated end plates, and it almost looks like a little bone kind of within a bone. And this is a finding we see with osteopetrosis. Lastly, Erlenmeyer-Flask deformity. The metaphyses take on an Erlenmeyer-Flask appearance that you may remember from chemistry. So osteopetrosis, marble bone disease, also known as Albers-Schomburg's disease. And so that has a few AKAs. All right, now rickets versus scurvy. If they present you with this diagnosis on boards, it's going to be in a child. Okay, rickets and scurvy have most dramatic radiographic effects on the growing ends of the long bones. So the growth plate epiphysis metaphyseal region shows the most prominent changes radiographically, hence why you always end up seeing a joint complex in a child when you're presented with these conditions. These are not clinically silent, conditions. Children are very irritable, both with rickets and scurvy. They generally have some nutritional deficit somewhere that's causing this to happen. And so, there's a number of kind of clinical findings associated with that. Radiographically, let's start with rickets. Vitamin D is really integral to the mineralization of bone, particularly the new bone we produce at the growth plate. And so patients with rickets end up with defective mineralization on the metaphyseal side of the growth plate. Think about the growth plate hypertrophying cartilage. That cartilage then becomes bone, and that bone needs to be ossified. So in the absence of adequate vitamin D, that ossification process is diminished and delayed, and they end up with a really indistinct metaphyseal margin. Instead of having a clean cortex up against a growth plate, they end up with this really hazy kind of white, what they call a paintbrush metaphysis. Imagine there's like bristles, like really fine bristles coming out of this area. So paintbrush metaphysis, along with the fact that they're really cupped. So they have this kind of concavity to them, and they're kind of frayed or splayed, kind of to diverge in its dimension. And so cupped metaphyses and paintbrush metaphyses are really characteristic. Patients also have reduced bone density in general. It's a very young child. You'll notice they only have the capitate and the hamate ossified, and part of the radial epiphysis. So they're probably about 2 or 3 years old. Patients also have costochondritis. So they have inflammation of the chondral ends of the ribs. This is what's referred to as the rachitic rosary. These would be little nodular, soft tissue kind of protuberances seen along the chest wall in a patient with rickets. Now, moving on to scurvy. Scurvy is has a different manifestation, and there's really over definition of the metaphysis and the growth plate in patients with scurvy. So it's kind of the opposite problem. They end up with really sharply delineated metaphyses where the metaphyseal margin is really dense. The epiphysis is really super well defined. Its cortical line is really prominent, right? And they end up with this kind of spurring at the margin of the metaphysis. So here we can see what's called a Pelkin spur. This is a little excrescence, I guess is the best way to describe it, occurring at the very margin of the metaphysis in patients with scurvy. And then at the metaphyseal margin, otherwise, there's 2 findings. One is a lucency just adjacent to the cortex, and this is called the scorbutic zone or the Trummerfeld zone, followed by a really dense cortical margin. And this is a dense zone of provisional calcification. They're over-calcifying their metaphyseal margin at the growth plate. So where rickets is really ill-defined, scurvy is really well-defined. Okay, that's a fundamental difference. This is called the white line of Frankel. Okay, there's a name sign associated with that. You can also see the really well-defined ring epiphysis. You can see this on either side, and this is a good example, kind of in both legs here. So this will be bilateral. This is systemic. Both of these are systemic vitamin O deficiencies. Rickets, vitamin D; scurvy, vitamin C. Okay. And in scurvy, you can see that the patient has this really wide metaphyseal margin because of that Pelkin spur. Okay, so lucency under the cortical bone. Then there's the white line of Frankel, the Pelkin spur, and the ring epiphysis. And that's the end of the slideshow. Okay, so just quickly, in part 3 examination, there is going to be, and let me go to this blank sheet just so I can kind of show this to you. Oh, I guess that won't work. Let's come back here. There's the actual sectional exam to part 3, right? Where you're gonna be presented with questions, maybe a scenario, maybe a print of a radiograph, and some of those clinical vignettes, okay? In the diagnostic imaging portion of part 3, in the written test. And then there's a separate x-ray test. And that x-ray test is 20 cases with 2 questions per case. So you'll have question 1 and question 2 associated with each case for a total of 40 questions. Okay. That examination used to be part of part 4 and now is part of part 3, which is why we're doing this radiographic board review, because all the stuff you could have learned between Rad 1, 2, and 3 could be on that examination. Okay. So when you're going into the part that's just the x-ray test, the actual diagnostic imaging test, imaging-based exam only, you want to be mindful, again, of the history. You want to be mindful of the radiographic findings and specifically what they're asking you. This is important because it's a case, right? So they're presenting you with a patient, their history, and then the images associated with that. And a lot of the questions are about like findings or a name sign or, a management component. There's always a point to remember about when you shouldn't adjust, right? So things like fracture, things like instability, scenarios where a patient may have like a cord problem, like in the case we saw of OPLL, patients can have effects on the cord. So the diagnostic imaging test is really to help you think critically around a patient presentation and imaging. So I just wanted to give you that little kind of gem to help you in kind of getting through that test. There's a little practice test associated with these lectures, so be sure on the modules page you take those quick little assessments just as practice to see, where you may have areas of weakness. All right, thanks so much, and good luck on your test.